which is 2010, the first 3 months, I believe it is now, of 2010, you can see that the health professionals are actually giving only about 36% of their money to Republicans. The rest is going to Democrats. Right? So, and then you see the pharmaceuticals, they're still playing close to the Republicans at 50%. Right? The hospitals, so hospitals and nursing homes are down around 23%. They've abandoned ship, and they've run to the Democrats. And the health services and HMOs on the other side are about 35% Republican, 65% Republican. Now, you can say, well, that's good reform. These people are now supporting Democrats. But what it really reflects, if you understand campaign giving, it reflects their need to influence Democrats. So Democrats are not so much getting this money due to support, they're getting this money much more due to the need of these organizations to move Democrats away from what otherwise might be natural positions. That's what campaign money is about when you're looking at it in this way. But if we really want to see where these groups lie, there's that old, expression from Hamlet, the play's the thing in which we'll catch the conscience of the king. Well, it's the competitive elections in which you will really catch the conscience of the big contributors. That's when they show what they really want. And then, after the competitive election, they start giving money to those in power and likely to have influence. But if you look therefore over here, you'll see the, again, competitive races. You see the same 4 groups: health professionals, pharmaceuticals, hospitals, health services. And here we have the 2 bars of 2006 and 2008. You will see that these groups, the dark red, you will see that all the numbers are above the 50% line. They are all heavily favoring Republicans in competitive races. So that when they have a chance to change the structure of the Congress, these groups lean Republican. That tells you where they really are. So we see these groups are the biggest givers. These groups are the biggest lobbying organizations. This is really where their hearts are. And you can look today and you can say, well, wait a minute. Many of the physician groups, the hospital groups, many of the pharmaceutical groups, even the health insurers are playing ball with Obama. They seem to be close, right? And I'm thinking, yes, that's true, but what I'm worried about is they seem to be close because nobody's hurting them yet. They seem to be close, and this is part of the problem with the current reform. They seem to be close because they're getting things in reform. Most of them are looking out at this and saying more money's coming in, not less. And it's only when they begin to see less money coming in that they may flip. And that's why I think Obama is having so much trouble with the cost side of this. Right now, they're still giving to get these groups on board. If they really want to get cost containment, some of these groups can act as hits. And I don't know how you get it from here to there. So anyway, that's a bit of a challenge. Economically, of course, this is the key problem. You've all seen slides like this, showing the rate of premium growth relative to inflation. This one stops at 2006, but 2007, 2008 are about the same. Healthcare costs, I mentioned this last night, going up 2-3 times the rate of inflation year after year after year. That's the fundamental economic problem. And that's what produces what I mentioned, the 400% a few minutes ago. I like to use this because I think it gives us an idea as to the nature of the economics of this and why this gets harder to do every single year we postpone. In 2000 or in 1993, when we were back doing this, the economics of this was much easier than it was today. It seemed hard then, but if you look hard, you see it's harder today. I put this up this way. In 2000, a family of 4 at 250% of poverty would have been making $44,000. A premium that they by 2007 they were getting $51,000. That would have been their income. So between 2000 and 2007, their increase in income was 17% as the poverty level went up. Right? If you look on the other hand at the health HMO family premium, it went from $5,800 in 2000 to close to $12,000 in 2007, an increase of 103%. So the family poverty level income of 250 went up 17%. The HMO income went up 103%, Which meant, if we wanted to say, okay, people at 250% of poverty have to buy health insurance on their own, we would have been making them, in 2000, spend 13% of income to buy health insurance. By 2007, we're making them spend 23%. Clearly unacceptable number for health insurance. So what that means is, when we look at what's necessary to subsidize, if we were to say to people, okay, nobody has to spend more than 50% of their income to buy health insurance, what that would mean is if the premium is now $12,000 or more, the income needed to provide that is $79,000, which means we have to subsidize up to $383, and now we are at 400% poverty. So rather than being able to subsidize at 200 or 250% of poverty, we're now looking at subsidies for 400% poverty, a steep climb. So here are the paradoxes I see in the challenges to healthcare reform. And some of these are in the monograph you have there. I think of, to some degree, health reform is a little bit like redistricting, like my old political scientist. You know, in redistricting, every 10 years we have to move the districts around, and every district has to be the same size. But if some politician in San Diego decides, you know, I need a few more blocks of this part of San Diego, that'll give me a slightly better cushion in the next election. And everybody says, okay, no big deal, 3 blocks here in San Diego. Pretty soon, you're moving Sacramento, because the districts have to be the same size. And somebody in Sacramento said, no, wait a minute, I don't like that change in San Diego, because it's moving 3% of the wrong population into my district. I had it set up before. Right? Health reform is a little bit like that. People say keep it simple, and it would be easier if you could keep it simple. But if you do this, you have to do that, and then you have to do this, and then you have to do that. 50% is paid by federal government, by government, 50% is paid by the private sector. You could barely move one piece of this puzzle without reshuffling the deck. And that makes it very, very complicated. One of the quotes I used in the book is from a friend of mine who runs the hospital organization in Washington, D.C. He said, health reform is rocket science. Right? So it is very, very complicated. You can't move just one piece of it around. And as you expand it, you bring on more funds. You bring on more people, and as you try to fix a piece, you find you can't fix that one piece and solve that interest problem, because that's one that spins out to 3 or 4 other interests whose problems you have to solve. So health reform is very, very complicated. Everybody says keep it simple, but you cannot. The next point I have up here is you can't have health reform without cost control. Everybody seems to conclude we need some kind of cost containment in order to get health reform. I've semi-concluded you can't have it with cost control either, because the opposition to various forms of cost control is so great. And that, I think, is the challenge Obama and others are wrestling with right now. Reform needs to reduce costs, but the easiest way to get success is to spend more, not less. It's always easier in politics to give out goodies. It's always easier to have an expanded pie, but right now we have a contracting pie. 43, 47, 48 million people need to come in, and we have a contracting pie. So somehow or other, balancing these objectives, I think, is a very, very difficult challenge. It would be much, much easier to do this in a booming economy. Much, much less challenging.